Hello, hello, everyone. Welcome to this edition of Ask the Experts. I obviously have a lovely face with me who I will introduce in like 1 second, but I just want to welcome everybody to the live stream. So if you are new to these live streams, because I know we met a lot of you at the conference in Chicago, every Wednesday at 12 Eastern, we have Ask the Experts. So I'm a licensed clinician. I also have OCD, unfortunately, but I'm a licensed clinician, and I bring on other experts. They may be researchers, they might be psychiatrists, PhDs, licensed clinicians, and we really talk about relevant topics to OCD, but mainly these streams are about you, especially when it's an Ask the Experts. We're going to get your questions. So whatever platform you're joining us on, if you're on X, if you're on Facebook, YouTube, LinkedIn, etc., Twitch, you're going to go to the comment section and just ask a question. So if there's anything specific to your experience that you want to ask us, if anything we discuss sparks a question, please ask that. But like I said, we're here every Wednesday at 12 Eastern answering your questions. So once again, chat. This is your live stream as well. You can also let us know where you're joining from. Are you here to support yourself? Are you a clinician, or are you a teacher wanting to learn more? Are you a parent supporting, or a sibling supporting a loved one? So let us know where you're from. Let us know who you're here to support. And we have an excellent hour ahead of you. As always, I do want to remind people that this is not a crisis hotline, so we can't step in for any kind of crisis. This really is educational. This is giving you direction and community. So if you are really struggling, please either contact your licensed clinician, 911, 988, or 988lifeline.org. Go to the nearest emergency room, but make sure you get that care that you need. We can't provide that, but we can definitely support you in other arenas. And then lastly, we're live streaming right now on multiple platforms. So if you have any kind of interaction with people, let's just make it nice and kind. That's all we ask. All right. Well, I'm definitely not here by myself today. I am with a good friend of mine. I may say that sometimes I have guests on, but Lauren is a great friend of mine. I'm in a great group chat with her. I am not as quick as all of them. They crack me up, but I'm super excited to have Lauren. We've been trying to get her on for a while. So I'm going to give the official introduction and then the friend introduction. So Dr. Lawrence, I said plural, there's three of you. Dr. Lauren Wadsworth, is a board-certified clinical psychologist who is passionate about expanding access to evidence-based mental health treatments, as well as furthering diversity and inclusion efforts. She's the founding director of Genesee Valley Psychology, GVP, an insurance-based clinic providing financially accessible evidence-based treatment to the Western New York area, with offices in Rochester and Buffalo. Dr. Wadsworth is also the founding director of Meridian Psychology Practice, a private pay clinic serving New York, Massachusetts, and Georgia. I'm so bad with initials with states. GA's Georgia, right?
Yeah, you got it.
American education right here. Passionate about increasing access to evidence-based training, she is a co-founder of the Mental Health Network and Training Institute, offering app-based training and consultations. She's the co-founder of Twin Stars Diversity Trainers, a consultation company offering diversion and identity-related trainings for organizations and leadership, and co-authored a related book, Did That Just Happen? Beyond Diversity, Creating Sustainable and Inclusive Organizations. Finally, she is a clinical senior instructor in psychiatry at the University of Rochester Medical Center. Okay, I'm busy, but you are super busy. Do you sleep? Do you got any free time?
Strangely, I do sleep well, but I think work might be my hobby.
I was going to say, you're like me. It's like people are like, what do you do for fun? Well, I do have a life, but a lot of it is dedicated to this community, which is amazing. And that's obviously how I know you from this community. It was good seeing you in Chicago, obviously at the conference, and always keeping up with you. How are you doing? How is life? How was the conference?
Conference was great. It was so exhausting and energizing at the same time, which I feel like is IOCDF conference in a nutshell. But yeah, it was wonderful seeing you, other friends, trying to get a couple winks of sleep in between days, and had a really great time giving a talk on OCD and trauma and running the OCD trauma SIG. So those were some highlights.
Yeah, and getting pizza with me had to be a highlight.
Oh yeah, well, it wasn't deep dish, but it was pizza with Chris.
Yes, that was the most important, and my mom. And we had her stay out way too late, 10:30.
Yeah.
time. No, the conference is great. I mean, it was super cool because obviously I do these live streams, sometimes from my house or my office, depending. I had a advocacy meeting right before this, so I didn't have time to go to the office. But no, it's just cool doing it. And then meeting people came up to me and were like, "Oh, I watch your live stream." Some clinicians, some people with OCD. So it was just kind of like an honor to meet the people that dedicate their Wednesday or watch the replay. So that's always exciting. Well, we are going to jump into a lot of questions we have pre-submitted. A lot of people ask live questions, but before we get into questions, I always like to ask whether it's in your practice, whether it was at the conference, whether it's just something you've been chatting with colleagues. Is there anything that is like, Liz calls it her like soapbox moment, right? Like I get those too, where it's like either it keeps coming up with clients or it keeps coming up. I know like at the conference and with clients lately, it's been like, is ChatGPT helpful for OCD? Are people using it for bad reasons? But is there something like that that's just kind of popped up in your world that you're like, man, this is something that I think this audience would either benefit from or need to discuss?
Well, it's a great question. I feel like we have a couple of those that we're chatting about right now at the clinic, GVP. So I know that you and I are both really passionate about values-based exposure therapy and really trying to get away from the old school methods of ERP where you just go up the hierarchy. Maybe you're licking a toilet bowl, things that that might feel like too much, might scare people away from ERP and might not be values aligned. And we're both really passionate about doing values aligned hierarchies. Something that has been a sticky point, which I know you've talked a little bit about, that we've been discussing in our clinic, especially lately, is when clients use values-based ERP against us as providers. And I don't mean that in like a manipulative way or like a negative way, but just I think there are going to be some confusion where folks might think that either an exposure is something that is values aligned and it's something I want to be able to do and I'd be proud to do, or it's not. And if it's not, it's something that I shouldn't do. So for example, let's say we'll just use contamination because it's easy. Let's say sitting on the bathroom floor is the exposure idea. And I could think of ways in which that would be helpful to be able to sit on a bathroom floor, but a client might say, that's not values-based ERP because I don't value sitting on the floor. And so trying to kind of figure out, well, where's the overlap of these goals? You know, it might not be a value of yours to sit on the floor, but it could be helpful to be able to sit on the floor if you need to potty train your toddler. And that's values aligned, right? So like how exposures might not feel like they're inherently values driven, but they could be leading you to a value down the line or a valued action. So just seeing is that that's something that we come up against a lot at our clinic because we really emphasize the values piece. And then a client can sometimes say, I'm not willing to do any of these exposures because they're not values aligned. And then how we, have that conversation from there.
Yeah, no, I love this conversation. I run a family and loved one support group. We ran it this last Saturday, 195 families. I was so excited.
Wow.
I know it was a big one. We met a lot of people at the conference that were like, we need a family group. I'm like, hey, I run one. You've been on it with our good friends, Amy. I saw Amy in the chat, and Allegra, who I think has a client right now. But, one of the things that we get asked a lot is that, right? It's like parents that will come on and say, hey, my loved one tried ERP, hates it. And I'll always kind of engage and just say, tell me a little bit about what your loved one did. And it was like, oh, ripping up pages of the Bible, or, like having to put their hands in a toilet water, or, scream profanities at their parents. I'm like, whoa, and it gives me that very like fear factor, shock value treatment. And that's not going to, a client's not going to click with that, because after treatment, they're not going to be cursing at their parents. They're not going to be ripping up Bibles, right? And so I think a lot of the work that you've done with justice-based ERP, the way that the field has moved with acceptance and commitment therapy, but all around just like better understanding of inhibitory learning of ERP. But that's what I was giving examples at the family group. And the example I always give is that a client that really struggled with ERP and was giving up treatment altogether. She was in high school. And when I asked her like what were some of the things she did at the last treatment center, it was like a lot of it was going out in the parking lot, putting her lunch on the parking lot ground, and then having to pick up the food and eat it. And she's like, sometimes I'd even feel gravel in my mouth. And I'm like, okay, I'm not even going to do that. So I was like, what do you like more than anything in the world? And she said chocolate. And there's like a big mall by my office and there's a C's candy. I'm like, what if instead of washing your hands ahead of time, we would just go with hands as is, and we go to C's, we get samples and we eat them. And then she's like, okay, I could do that. And I was like, tell me how that translates to how it would be valuable in real life. And she said, well, a lot of times, like I was at the movies the other day with my friends and I wanted to run into the bathroom, wash my hands because they offered me to like snacks. So I just lied and said I didn't want some, but I want to be able to just like grab snacks with my hands. And I'm like, cool, this will translate to that. And it was totally like fun for her to do treatment. And there's a movie theater across the street. We didn't go see a movie, but we went and got movie theater popcorn and like walked around the mall and ate it. So, a lot of the work that we even talked about at ADAA together, I just see people much more engaged, more bought in, and treatment doesn't seem so negative or hurtful.
Mm-hmm. Absolutely.
But it is finding that balance, like you said, of like how, how do you have somebody not then say, well, my value is to never do exposures.
Yeah, exactly.
My value is my parents open the doors all the time.
Mm-hmm.
Yeah. What's an example of like maybe in your clinic that you had somebody work and kind of had a discouraging outlook on OCD treatment altogether, but you feel like this mindset of treatment really helped like turn it around for them or helped with buy-in?
Yeah, so I'd say a good number of our clients have tried ERP in the past, or they think they have tried ERP in the past, and then they come to us. Something that we do that's a little different than how I was trained was before we dive into the hierarchy, we do a values card sort or just a conversation about values and ask them what things has ERP gotten in the way of that you value. What would it look like if you lost your symptoms? What types of valued activities would you be able to engage in? We map that all out so that when we do the hierarchy, we can link each exposure, as you were saying, Chris, translate to how that will help you live a life more in line with your values. So most people come in not excited about exposure or come in pretty jaded. But the fact that we're able to really, before we even jump into anything about ERP or OCD, just figure out where are you at in your life? How in line are you with your values? Usually the answer is not very much. And then what if I told you if we did this treatment, your life could look so much better, so much more in line with your values? And I think it's a much more empowering approach. I know that you believe in that approach, and it just can really fuel people and help them get through the exposure. So when we start exposures, we ask them each time they set an exposure goal, we ask them to say, how will this help you live more in line with your values? And we make sure that we're reiterating that every time we're doing exposure.
Yeah. I don't know if you felt this at the conference too, but there was like a lot of hope. I felt a lot of hope. And I was able to hear stories from some people with lived experience talk about getting better. For the people watching this, whether it's because they have a loved one with OCD or they have OCD themselves and they're really struggling, what do you see either in practice or at conferences or podcasts and stuff about hope and about people getting better?
I think that there's just so much hope. To me, OCD feels like a math equation, and we usually can figure out the way to solve it, and that's not by thinking, it's by doing. And I think the OCD Stories podcast has so many messages of hope. I think all of the influencers out there like Allegra provide so much hope for people. And then in our clinic, we have open drop-in groups of all different kinds, but we have people that have been through the whole process and are doing so much better that give hope to the new people. So I think the fact that the OCD community has a lot of community with people that are newer, that are in the middle of treatment, and that have been through treatment successfully, the fact that it has clinicians with lived experience that are willing to talk about their personal story and share about how they're doing well now. I mean, that's so unique to the OCD realm of mental health that I'm not sure people really fully appreciate how cool it is that this live stream exists, that someone with lived experience who's a clinician runs it. I mean, that's unheard of in the depression world, in the psychosis world, and the social phobia world. So I think those are big things that give hope. Seeing people living full lives, coming back to the conference, helping people as coaches or as therapists or whatever they're doing, to say, I got through this and you can too.
Yeah, it's so interesting you mentioned that, because I had a couple clinicians come up to me at the conference and say, hey, I'm like really worried about self-disclosing, like how do you self-disclose, et cetera. And I remember in the beginning I didn't. And even though I would have people come to see me because they knew my story, I just remembered how I was like methodically trained in grad school of like, reflect, like, well, tell me why that interests you. I want to hear a little bit about the meaning behind that question. And people were just like, well, I heard you got better from OCD and I want to get better too. Like, what do you mean? What's behind this question, right? So I remember having like a talk with people in the field and like talking to my supervisor and talking to my even some of the people in grad school, and I was like, I don't make treatment about me, and I don't sit there and like tell my whole story for a session. But sometimes clients will just say like, hey, on those hard days and you're having a sticky thought, like what worked for you? Or I run support groups and people ask that. So I think for clinicians watching this, because we do get a lot of clinicians watching it, obviously it's not a you show, you don't sit there and like open up, but if the client asks or engages about it, it is absolutely okay to reflect a little bit. I think people like to hear that. It's kind of only unique in the OCD and sometimes substance use world, but you're right. Like every other clinician has this pressure to be perfect and never open up about their life at all. So I'm glad we don't have to worry about that.
Yeah, no, it's great.
Yeah. For people that are just watching this and where do start? Where do people start? Like, let's say somebody's watching this and either they feel like frustrated and stuck, or they haven't gotten treatment yet, or they've tried treatment. Like, where do people kind of start their journey to get better from OCD and related disorders?
Well, that's another thing that I think is unique about the OCD world that is so great. There are so many places. So these live streams are a great place to start. Searching OCD Stories podcast, and then your theme of OCD or recovery stories is a great place to start, to just be able to build that hope. There are amazing books written about OCD that are self-help, that are treatment manuals. There are so many books that are just memoirs that you can learn about people's journey. And then when you're feeling ready to start treatment, looking at the IOCDF website, iocdf.org has a Find a Therapist tool that we refer people to every day, where you can find someone that does ERP in your area. The IOCDF also recently published their treatment recommendations, and those have been updated to state that ERP and medications and the combination of them are the first line treatments for OCD. And then if those aren't something you're willing to do, or you've tried them and they haven't worked, which I think we can get into some caveats with that, there are second line treatments as well that folks can try, like ICBT and others that are still being researched to make sure they have the same level of effectiveness as ERP, but that are definitely things that are worth looking into. So those are my top recommendations for folks. You want to, in my opinion, start with ERP and make sure that you're with a provider that is trained in ERP and doesn't just say they do OCD. They didn't just check the box of OCD and Psychology Today. They know what ERP is. They plan to do that with you for 3 to 4 months on a weekly basis, doing exposures in session before trying other treatments. So those would be the things I'd be looking out for, making sure that you're doing ERPs in session with your clinician, talking about how they're going, incorporating values, and really doing the work together as opposed to just talking about it.
Yeah, no, I'm glad you talked about the guidelines. We went over I had Steve Poskar, Dr. Poskar, on the family group, and we went over the guidelines just to explain, and also what people can expect beginning, middle, and end of treatment. But there was like a cool story that a dad shared that their son really just like found ACT super, super helpful. And even though like there was basis in CBT and ERP, it was really ACT that spoke to him. And I had somebody in my support group, same thing. And so we have a lot of good treatments. We know where to start, and we know that there's a great adjunctive treatments. Obviously, really one thing that kind of seems exciting is there's a lot of like medications being studied on the horizon. So I tell people it's a really good time. It's never a good time to have OCD, but it's a really good time to have OCD because there just seems to be so much excitement like moving in the field. So I'm always
It's never a good time to have OCD, but it's a better time than ever.
yeah, yeah,
That's the way
exactly.
to say it.
Let's put that on a shirt. I like that. I like
Yeah.
Before we jump into questions, what is kind of for you personally as a clinician, like when you're working with someone, there's a talk at OCD Southern California's conference that I'm going to do with Kim Quinlan, and we did this talk in person, and we talked about like these like 8 roadblocks we commonly see with people, and like what people that are doing well in treatment are doing versus people struggling. So for you, what is your top 1 to 2 things that you're like, hey, these are the things that seem to be common, either like good things that people that are thriving in treatment do, or these are the things that if people are struggling, typically this is kind of occurring. Like I always like when
Mhm.
somebody comes in and says, hey, I'm moving my schedule around, my life around to really prioritize treatment. Like this, my mental health is my platform. I need to make sure to do something so that my mental health is finally addressed first. I've always kind of been putting it on the back burner, but I think now is the time. Like something like that is an example that I tell you, yes, that mindset is going to get you better. What's something either that people thrive in, or you're like, hey, be cautious about this. This could kind of be a roadblock for you.
When people come in and say, I know this treatment is going to be tough, I am willing to do whatever you tell me to do to get better. And I'll say, awesome, but it's going to be a conversation. I'm the GPS, not the driver. I'm not going to tell you what to do. I'm going to tell you what's worked for other people. And it's up to you if you want to do it. But that mentality of like, I know this is going to suck and I want to get through it. I'm willing to do whatever it takes. When people approach it with this like athlete mindset of, I know it's going to hurt at the gym, but I'm building muscle. When folks are willing to do it on a regimented basis outside of the therapy sessions. So they're doing ERPs between sessions and we're doing them together. Those are always super, super green flags. Red flags to me are when someone isn't doing homework between sessions. They're not starting to build this ERP lifestyle. They're really not willing to feel anxious by choice. And another thing that could be related to that is when there might be a secondary gain. So if someone is in a situation where their OCD has made it so they're not able to work or they're not working, that can be a little bit of an orange or red flag for me if they're not dying to get back to work. If they're not dying to get back to a busy life, then it could be that OCD and having a less busy life in terms of leaving the house can go hand in hand. And so motivation can be lower if it's the idea of working seems worse than having OCD, if you know what I mean.
Yeah. Yeah. And I always tell people, because I think sometimes people get defensive about secondary gains. And I always tell people, like, I had secondary gains. I know, like, when I was getting better and I was at that point where it was kind of like last stages, right? Like, I could really hit the finish line. A lot of fear jumped up because I had been sick for so long. And I was thinking, oh my goodness, like, if I get better, like, really do this and finish treatment, there's going to be a lot of expectations because I finished treatment about 24. And I was like, people are going to expect me to have a job and like move out and, be able to like handle myself like an adult. And I don't feel that way because my life has been so consumed by the disorder. So I remember at the end, I was like a go, go, go in treatment. And at the end, I'm like, just kidding. Can we slow it down? But luckily, like my therapist said, hey, like, I want to introduce you to this concept of secondary gains and how there can be some purpose for you to not fully get better. Let's explore that. And I think it was helpful. I had a conversation with my family, explain the fear, and they're just like, look, we don't have those expectations. Sure, we want you to thrive, but we don't expect you to be CEO tomorrow. So I think it's just exploring like, hey, by not getting better, what is something that you're getting from it? Is it comfortable? Is it safe? Etc.
Is it known? And that can be a big part of it too, is I know my rituals. I know what my day looks like. I know it sucks, but I know what it looks like.
Yeah.
And, the idea of encountering social anxiety or panic or being stressed from work, that might not be very appealing. And I'm not coming from a place of like everyone should be working 40 hours or 100 hours a week, but I just know that when people are busy, OCD has less energy to thrive. It has less fuel to feed it. And the sooner we can fill up someone's schedule with things that excite them, that give them self-efficacy, pride, relationships, the sooner OCD is going to slowly shrivel away. That, that if we have unlimited time for OCD will take all the unlimited time and get stronger and stronger. So in my mind, we're early in treatment thinking about how can we add in volunteer activities, a class or two, some work, a couple hours a week, just to crowd out a little space from OCD.
Yeah. And I always remind people you can start with volunteer work. If a job seems very anxious, to you and you're just not in the headspace, start with volunteering, get out of the house, something. I think of it like a TV, right? Like if you only have one channel, OCD all day, that's all you're going to see. But if you now have competing channels, it's like, hey, I'm going to go away from OCD today and go watch volunteer or my job or dating or getting a pet or whatever it is that you want.
Absolutely.
Well, Wadsworth, let's jump into some questions. I love your last name. It's like, let's do this, Wadsworth. This is a pretty heavy question we'll kind of start off with, throwing it out there. Ian from Facebook says, please help. I have a 24-year-old daughter who has been waiting 3 years for inspiration from God for her music career and will only make money through music, refusing easy side jobs to sustain herself. She lives with her grandma who supports her. She is not formally trained in music. She had straight A's in college, majoring in marketing, but that has apparently been wasted. She denies having this much OCD. Now she is fasting to get the inspiration, I believe. She weighs 88 pounds. The question got cut off, but I'm going to guess it says, like, how do you get someone to have some insight or clarity or being open to kind of getting treatment when they're maybe at that stage where they're really like locked in to certain behaviors that are just not serving them?
So tough. So tough. So just want to validate that there's not some magic statement that you haven't said yet or some, perfect plan that you haven't proposed. I'm sure you've tried so hard to communicate with this person that you love them and that you want them to get better and that you see OCD as this big monster that's taking away their life. So just to validate it, so hard to watch, so hard to watch in our family members, especially those that we feel like have so much promise that isn't being actualized in this moment. So just heavy validation there. Some things that I recommend when folks are that locked in, to use your term, Chris, I think that's a great one. Number one, I think about if the person's not willing to do ERP at this point, would they be willing to consider a medication? Is there a way that you could frame the idea of medication that isn't about you need medication so that you can give up this music career, but hey, you seem really anxious all of the time, maybe a little depressed. I'm wondering if it might be helpful to talk to a psychiatrist. Just because when someone is that locked in, it can be hard to have enough space to start to try new skills or learn new skills in therapy. So if someone's in that extreme place, I might try to start with medication. Oftentimes people with OCD are scared to take medication, are scared to feel different, or take a medication that will have side effects. So if that's a no-go, that wouldn't be totally out of the blue or abnormal. I might, again, share similar stories. So finding a memoir of someone that's similar, that has gone through that level of symptoms and then gotten better, maybe sharing an OCD Stories podcast of a musician who has recovered, something that would be in line with how they identify, which then might make it easier for them to accept that they have OCD. I also think it can be helpful for some folks to start with more general talk therapy before jumping right into ERP. Oftentimes people will come to us for ERP and we'll say after 6 weeks of trying that they're not quite ready and they might need more general therapy to help them build that motivation first. So maybe starting with something like that. Those are some general thoughts. I'm curious what you think, Chris.
Yeah, I mean, I really love Alec Pollard's work on what to do. He has a book that's with some colleagues about what to do if a loved one won't get mental health treatment. We know the SPACE program through Ellie Leibovitz out at Yale really works on what parents can do differently. So I think I like to hit this with a two kind of prong approach. As one, how is the family? He said she lives with a grandma. Like, how is the grandma accommodating? I always remind parents and loved ones, the goal of accommodation is not to pull back safety, right? So you don't have to kick them out on the streets and not feed them or something. But how are there other ways that some of this is getting reinforced? Could you look at a different way to approach your loved one? Maybe if you continue to hit them with get treatment, they're not there yet. But are there some changes that you as a family can make that may make the person a little bit more have a little bit more insight that, hey, maybe something's wrong. Because a lot of times people don't realize that there's something going on if all of the family members are holding it up. And as if people slowly pull back their accommodation, people feel the weight of the condition. And then lastly, I say sometimes meeting the client where they're at, like you said, maybe jumping into OCD treatment is not where they're at. It sounds like they admit they have OCD, but not the severity. So what if you talk to them about the distress? Like, hey, could you see someone? And just talk about the distress. You're probably frustrated that the music career hasn't happened yet, or your weight, you might be tired or having a hard time concentrating. So sometimes just meeting the client where they're at and what they're willing to get some help for, whether it's talk therapy or whether it's anxiety therapy or just something, match their distress if they're not willing to get OCD specific treatment if they don't see it.
Yeah, I definitely want to underscore the recommendation for SPACE. So SPACE is an acronym for those that aren't familiar, and it's a treatment that is for the family, not for the person that has OCD or anxiety. And it is shown to be as effective as individual therapy for children or teens, and probably likely adults too, but I don't think that study has been done yet. Maybe it has. I got to catch up. But SPACE would help the family structure the way to reduce accommodations in a way that's compassionate, is informed by evidence-based treatments, and ultimately might look like making this situation a little more uncomfortable for your daughter before it gets better, so that she feels more motivated to reduce some compulsions to get her needs met. But yeah, I appreciate you saying that, Chris.
Yeah, no, I have clients where I've never met the client. I work solely with the parents or in some cases spouses, and they always say that. They're like, this has been the most helpful thing because I've always been frustrated addressing my energy on how to change the person, not recognizing that some of the things I were doing were facilitating that. And so there was a client I worked with, and she started making changes about how she moved around the house. She did it with love and with compassion, but explained like, I need to start feeling comfortable living in our house, right? Like when I married you, I still want some independence and I can't move around the house in a way that OCD demands. And just by making changes, it had him being open to some changes too. So do not discount the power of SPACE and other treatment that focuses on you getting help if your loved one isn't ready. I didn't talk about
the support group.
Yes, absolutely. Or every second Saturday of the month, I run a family and loved ones support group. Just like this live stream, it doesn't replace treatment. It's a lot more about resources. We have special guests on. So if you email us at info@ocdsocal.org, we meet every second Saturday from 11 to 1 p.m. our time, Pacific time. I didn't talk on this at the conference, but I'd love to get your impressions on it. And a couple people asked for this. At 12:06, Kay asked, how do I do the exposure response prevention for real event OCD?
Yeah. So do you want to give a little background, Chris, on real event OCD for folks that aren't familiar? And I'm happy to answer the question since you just
absolutely.
talk on it.
Yeah. So real event OCD, there's different subtypes of OCD, and OCD is OCD, but sometimes it's helpful. I always tell people no subtype is worse or better, but they're unique. Each of them have different unique challenges. And real event is typically where an event happens in your life. A lot of times it's a long time ago. It could be a decade ago, 2 decades ago. Sometimes people come in and maybe it's like 8 months ago, but it's rarely like the day yesterday, right? And so what happens is people had an incident. During the incident and after the incident, they didn't think much about it. They've moved on with their life. And then whether a thought comes up, sometimes it's triggered by events in the media or a comment somebody said or running into an old friend. They start to spiral and kind of ruminate about that event and start to question, like, did I do something wrong? Did I do something illegal or immoral or bad? And so I think the challenge that a lot of clients will articulate on this subtype is they're like, but this event really did happen. But there's a lot of doubt around what specifically happened. And I always remind clients, I don't even remember what I ate for breakfast yesterday, let alone what I was doing 15 years ago. But clients are desperate to try to get clarity about past events and if they did something wrong or hurtful.
So usually with real event OCD, I actually start with a heavy emphasis on response prevention. So before we even jump into exposures, we're talking about what do you do when the thought comes up, right? As Chris said, that you're thinking about this real thing that happened. thousands of times a day in some circumstances more. Or maybe it's a few times a day, but then it's hours or minutes or however much time thinking about it and trying to be like Inspector Gadget with the memory. How can I go through it in a different way where I'll remember more? Who could I ask about what happened? What photos on my phone could I look at for clues? So starting with reducing those behaviors. When this thought inevitably comes up of what was I doing at that bar 10 years ago? Did I hit on a minor is a common one. I was drunk. How could I know? Maybe my inhibitions were lower. When those thoughts come up, how are you responding to them? So can you take off your inspector badge, put it on the table, and refocus on what you were doing before that thought came up? Can you get back into a values-driven behavior? Can you try to not engage in reassurance seeking by asking your friends that were there if you did anything weird or hit on anyone? Can you not open your photos app or look at your calendar for clues? So reducing those behaviors first. Maybe after you get into treatment a little bit, you can learn about why am I blanking on the term? Non-engagement responses, and practicing those every time the thought comes up. So, oh my God, what did I do at that bar? I'll never know. And that makes me really anxious. So you can validate your anxiety, say uncertainty statements. And then when we're doing exposures, that might look like scripting. So you might script about never knowing exactly what happened that night, all the things that could have happened. Folks are in all different places right now on the best way to do scripts, but in general, we're aiming at trying to trigger that core fear of not knowing. And sometimes a script can be as simple as one line saying, I'll never remember in complete detail what happened the night of, January 15th. Or I'll always wonder if I did something bad. Or I might have hit on someone and I'll never find out, right? So it could just be something like that you're saying over and over again. It could be looking at pictures or talking to these friends doing the things that trigger the thoughts or the anxiety related to this memory, and then just not engaging in the rituals afterwards. So it really depends on the person, but we want to reduce that Inspector Gadget behavior. We want to increase approaching things that you've been avoiding, and what the exact plan is would depend on the person's particular OCD.
Yeah, great things. I think the only thing I'll add is one thing we talked about in the talk is like one of the hidden kind of compulsions people do for this subtype is a lot of self-punishment. So feeling like you don't deserve love, you don't deserve certain things. I was giving an example at a client with real event OCD who wouldn't even like get extra guacamole on their their burritos, or if they went to Chipotle, because they're just like, who am I did this horrible thing many years ago, I got to feed myself to survive, but how dare I get like extra guacamole, or like go to Disneyland or something, right? And so I think be careful of that. OCD is going to try to rewrite your identity with this subtype, and we buy in, and then that doubt, but also that sadness and that shame and that guilt that comes up feeds the OCD, and we get more desperate to get clarity. The hardest thing with OCD is recognizing you're ruminating, right? But always remember, like if it's a monologue, as soon as it becomes a dialogue in your head and there's a tension, there's a back and forth, there's a review, there's a replaying, there's a challenge, any of that conflict in your head is ruminating. And that is the same as somebody who washes their hands or redrives around the block. You got to make sure that your day is not filled all day trying to replay an event, because we just won't remember something 15 years ago, let alone like 15 days ago. So.
Yeah. Let alone 15 minutes ago.
Yeah. And I always remind people, when you drop the OCD, you really abandon it, you're not giving into it. Typically, that's when we get clarity, right? Like the aha moment you want. Or you may never get clarity, but you're at least comfortable with the amount of information you have. But when you engage with OCD, I know it's tempting, you will always have more confusion. Compulsions equal confusion. You will never get an aha moment by ruminating. It just doesn't happen. I like this one. Austin asks at 12:09, how can I gain trust in myself when I have OCD? Because I think that's something we lose, right? Like we stop trusting our environment because everything feels dangerous. We stop trusting others because they can't do it right. We don't trust ourselves because we might make a mistake. I might have left the stove on, or I hit somebody with my car, or I said something blasphemous about God and don't remember. So how does treatment help people regain trust in themselves?
Yeah, that's such a great question. And I think one of the hardest things about having OCD is that you lose that trust in yourself, or you can. And sometimes that looks like not even believing that you have OCD or trusting yourself that you have OCD. Maybe I am just a bad person and this is an OCD after all, right? And that it's just can be so unsettling in my mind. The image is like it feels like you're turning inside out. Like, who am I? I don't even know. I can't even trust myself. Like, can't trust anyone else. And so, a couple things I'd say. Number one is in the short term, not trying to have a goal of trusting yourself when you're feeling triggered. So, if you're having that dialogue or you're feeling anxious about something related to OCD, trying not to have a goal right now of feeling trust in yourself when you're feeling triggered, because that's like the nirvana of OCD. That's like when you're in Chris's position and he's got so much awareness, so much insight, so much practice that he can say, I'm really triggered right now and I need to trust myself that this is OCD. So I wouldn't say that's like a first line goal. So if someone's earlier in treatment, I would encourage them to think about, how did you feel about this kind of thing before you had OCD? Or before your OCD focused on this, how did you feel about it? Can you remember what that felt like? Can you remember what it feels like to trust yourself? And we don't have to use that as evidence, but just remember that there was a time where you felt trust on this topic. And that's evidence that that can happen again. Also, reminding people that there are so many ways in which they're trusting themselves right now that are not related to their OCD theme, that it's really these one or two or three or five things that they don't feel like they can trust themselves on. It's not everything. If you drove here, you trust yourself, to work or wherever you are right now, you trusted yourself enough to get there. Maybe your OCD focuses on driving, so we're not going to use that example, but you trust yourself to take care of your kid, or you trust yourself to make food that's not poisonous. Of course, all of these things could be triggering about someone's OCD, but remembering that there are a couple things your OCD focuses on where you don't feel trust, and oftentimes you can trust a lot of other things about yourself.
Yeah, the only thing I'll add is, a lot of times people will tell me that they're hearing people talk about certain treatment modalities, this idea of like, you can, get answers and resolve things and da da da. But what I also say a power in ERP and a power in CBT is, it's not always knowing if a bad thing is going to happen or not, but it's trusting that if it does happen, you'll land on your feet. So obviously I call OCD as like very dramatic, right? She's in a telenovela and everything is doom and gloom, right? Nobody comes into our offices, Lauren, and is like, I'm afraid of getting slightly sick. Or what if I bump into a parked car? It's like, I'm going to hit people and kill them, or I'm going to run someone over, right? God is going to hate me. Like everything is so doom and gloom. But little things may happen, right? Like we may get an offender bender, or we may get frustrated and bang our toe and yell something blasphemous out, right? But there's this idea people have with OCD, like, I won't be able to handle it. And then when people do, they get thrust into a situation, they suddenly land on their feet and they're like, oh, I was able to manage it a lot better. That's trust in self, to say like, hey, if good things happen, awesome. If something challenging occurs, I can still land on my feet and handle it. I had a client draw his OCD experience, and it was like this big dragon. He was this small little thing with a toothpick. And I'm like, that's what OCD tries to market itself. But the opposite is true. We are big and powerful, and OCD is a little squeaky thing that we don't have to always give into. So Bonnie asks at 1209, I've had OCD for 40 years. This is my first time trying ERP. I feel like I'm treatment resistant. Nothing works. Do I need a higher level of care, like a PHP or an IOP? I definitely have opinions on this, but I'd love to hear what you have to say.
I mean, I definitely have opinions on this too. I hope we agree, but if not, great.
Yeah.
So a couple things. My first red flag is this ERP that you're trying? How do we know if it's good ERP or not? Does this person specialize in OCD? Have they talked to you about values and how that can be incorporated into treatment? Do you feel like the pacing of the ERPs is too hard? Do you feel like you don't know how to do ritual prevention? Do you feel like you're too anxious to do ritual prevention? There are so many questions. I'd have hundreds really about what the ERP you're trying is and if it's good enough or working. So It could be that you might benefit from a higher level of care. It could be that you could benefit from a different therapist. It could be that you could benefit from other changes in life that could make it more accessible. It could be that meds could be helpful. So again, if someone's in this place, I do think about medications. If it feels like you've got a good ERP therapist, you trust them, you've got a good connection, this is what they specialize in, they have good outcomes, but I just don't have the space in my brain to learn something new, maybe it's worth trying a medication, even if that's really scary. If it's still the case that you're not making any progress or feeling any traction, maybe is a better word, in outpatient, I love higher levels of care, partial, IOP, residential. I think I know that people don't want to take the leap, leave their lives to do them. And as someone that trained in partials and at the OCDI residential program, it's just such a gift to be able to do that kind of thing. So if you can do it and your symptoms are at a point where your provider thinks that level of care could be helpful, I say go for it, because that is a team of people that is so passionate about treating your particular thing. If it's an OCD clinic, you know you're going to get OCD treatment from a group that only does this all day, every day with really severe cases. I think people can make amazing progress. Oftentimes, the first couple of weeks are really exciting because you've broken out of your old habits and you can start to be in a new environment and learn new skills. So if you feel like you might need that and you're willing to do it, I'd say there's probably not much of a downside if it's something that's accessible to you. And I would just make sure, if you can choose a program that is OCD specific, that's your best bet, because there are many programs that will say they do OCD treatment, but are really a hodgepodge of all sorts of general treatments. And I would avoid those as a first attempt.
Yeah, I mean, the reason I'm so passionate about this answer, Bonnie, is because I work in a higher level of care. We have an IOP and it's one-on-one. And I've seen clients, even with me, not make progress on a weekly basis. And I think of it, if you think about medication, right? If you're really, really experiencing horrific migraines, maybe you have something at work fell on your head, right? And you're experiencing migraines, you wouldn't take children's Tylenol, right? Like, we get the right dosage of medication when it comes to, if we have a cold or whatever that may be. We got to do the same in OCD. So if your YBOX score is really high, you're struggling on a daily basis to function, seeing us for 50 minutes once a week when there's 167, I think, or 68 hours in the week outside of treatment, it's really difficult to make a dent. And I see people come to an IOP with me, or I've referred people to Liz McAville's OCDI in Houston, or people have gone to partial hospitals, mainly in Rogers and SoCal, and people are a different person because they are dedicating multiple hours a day, multiple days a week to really getting better. So I know higher level of care sounds scary, but I can say, as somebody who works in one, I see people change their lives in 3 weeks. So definitely look into that, and always ask your OCD provider. If you've done everything that Lauren talked about finding the right provider, you can always then turn around and ask, do you think a higher level of care would be helpful? We like to be honest and support that. MP asks at 12:27, I have a patient who has been doing great for some of the initial exposures, but is struggling a bit with the response prevention part. Insights on that?
Yeah, that's a tough one. I see that too. People that are all about doing the thing and then really struggle with the aftermath. So some things that I would be looking out for is this person white knuckling exposures? If the goal is to touch this chapstick, are they doing it like, okay, yeah, I'm going to do it today, and then they do it and they're like, ugh, or are they doing it like, okay, I'm going to do it today, let me hold it, I've got this, I feel so anxious, okay, I'm going to keep sitting with it, right? Like, are they really leaning in, or are they like powering through it? If they're powering through it, I would encourage them to slow down, to maybe do a lower level exposure that they can lean all the way into, notice the urges to ritualize, and then challenge those urges at a lower level exposure. If someone can do exposures but not ritual prevention, I'd say go down in the hierarchy, go further down until they can do the exposure and the response prevention, and then build back up. Making sure that you've covered non-engagement responses with them. I'd say that every day, because OCD is a very verbal disorder typically. So just saying don't respond is often really tough for people with OCD. So saying don't respond in the way you have been, but say this instead, even if you're saying the same thing 50 times, as long as it's not a compulsion, using non-engagement responses can give someone something to do, which can feel a little bit better than doing nothing. It's not to say those reduce the anxiety. They don't. They're not a magic cure. But those are some things I look out for. But in short, I'd say checking those things and also making sure they know what to do outside of session and how to practice this. Is it that they can do the exposures with you, but not on their own? And then how can you bridge that gap to make the time between sessions as similar as can be as the time with you in session so that they can really benefit from the treatment?
Well said. I always remind people it's from Alec Pollard, little e, big RP. It is more important for the client to buy into the response prevention. So if you have to make the exposure slightly smaller, the RP is so important. There is two questions, one from Bonnie and one from Ashley. I actually put those questions, just so you guys know I'm not ignoring you. I put those questions every second Wednesday of the month. We have a psychiatrist on. And one question is about a stroke in the basal ganglia, and another one is about nutrition deficiencies. I put those at the top of the list. So when we have our psychiatrist on the second Wednesday of August, don't make me look that up because I don't know what day that is. I promise we'll get to those questions. So I don't want people to think we're ignoring it.
Yeah, maybe Susan's too about how to start taking a med that's been on the shelf for 4 months.
Yeah, Susan, I'm going to put that question for the psychiatrist as well. Just a quick thing, just from a lived experience, not a clinician experience. I know for me personally, I was very anti-medication. I had so many fears around it and did my first 6 months of treatment without medication, but it really, really, really hit a plateau. And what really helped me take the medication is I found a psychiatrist that specialized in OCD and related disorders who didn't see me for 5 minutes and then pushed me through, like really sat down, answered my questions. I want us to clip it. Emilio, remind me, we had Dr. Hudak on the live stream a couple months ago, and he talked about how SSRIs are the safest medication he prescribes. He prescribes all different medications from all different conditions, but he said SSRIs for OCD are some of the safest medications. We have the most longitudinal data for it. They are clean medications in the sense that once you get off them, any side effects go away. So I think I got those answers from a compassionate psychiatrist that spent time with me. And it felt like the pros outweighed the cons, and I just did it. And I think once I started taking it, the momentum came. But we'll definitely ask that for a psychiatrist as well. So yeah. Ashley said, I feel like the term saying the client is not motivated make it sounds like an OCD is a choice. I hope you don't hear that from us. I think what it means by not being motivated is like, I mean, I always think about it in my own case. I don't think I would have. I always used to say I regret not getting treatment sooner. But I think about it like, I don't know if I was approached at like 15 when my OCD started really bad, if I would have been open to treatment. I think I had to be at a place. I think instead of motivation, we have to be at a place that we accept and receive change. And a lot of times we're just not ready for it. I think in high school with body dysmorphic disorder and OCD, I was so wrapped up into that. And I know that when we didn't know what it was, but when family tried to intervene and get me general mental health, I just wasn't there. So I think that's one of the things that we just have to be at a headspace that we're open, and whatever that looks like. You know, if somebody just doesn't show up to a session, that's what we kind of mean is like the person may not be at a place that they're ready to receive help. It's not bad. It's not a judgment. It just might be like they're not ready.
Yeah, and I think figuring out in treatment, like how can we get the person from wherever they are, if they're resistant or whatever it is, whatever term you'd prefer, to getting to the place where they realize that rituals can be a choice, that they can resist them if they choose to. And I'm saying that I know that can sound really controversial. I'm not saying that OCD is a choice. I'm saying that ERP and the theory behind it is that we can make a choice when it comes to rituals, not the obsessions. And sometimes it takes a lot of support and structure to get someone to a place where they can start making that choice. And so those would be the questions I'm asking is how can I get them to where they are now to being able to make that choice?
Yeah. Mary O asked about what if we know exactly what we did. This is at 12:42, Emilio. What if we know exactly what we did during the real event and feel extreme guilt about it? We actually addressed that in the call. I think Liz McInville handled it really well. Sometimes we have done something that we don't absolutely love that we did, and I think that's part of the human experience. Is we are going to make decisions that aren't always great, right? And part of the uniqueness of real event OCD is typically it's when we're younger, and now with an adult brain we're able to look back, or a sober brain or whatever it is, we're able to look back and do really good, backseat driving of why did I say this or why did I do that, etc. Like Liz McInville said, and I think our talk was recorded, so you can watch it back if you purchased a registration. But sometimes there might be something you need to do, like apologizing or look something up, if it's not compulsive, and that's something to decide with your clinician. But if there's nothing you can do, part of our life is just learning to let things go. And I think that's what happens with OCD, is because it's looping so much, we mistake that urgency for like something needs to be done, where sometimes in our life we're so activated, right? With OCD, we're always kind of doing something that feels really irresponsible to let go. But that's what the acceptance component of OCD treatment is finally saying, okay, I feel guilt around something I did many years ago, and if I could fly back in time, I'd change it. But since I can't, how am I going to move forward? We in therapy, we have a big trust that people can learn and shift and change and grow, and got to have that for yourself. Somebody asked at 12:58 from Jenny, I feel like I'm actively resisting OCD. Like I don't think I have it, but my sons do. I feel like it is crouching at my door, waiting, wanting me to spiral out of control with my anxiety. Does anybody else feel this way? So Jenny feels like she's resisting it. She doesn't think she has it. Her sons do. She feels like it's crouching at her door. So maybe somebody, I think this is a good question in the sense of like, what if you have a family or a loved one who has OCD or related disorders, and as you're learning more about it, you think like you might have it. And if your loved one is really struggling, the fear of like, what if I end up really struggling? What's a good way for family members thinking they may or may not have OCD to kind of get started?
Yeah, I'm trying to understand the question. I think I'm wondering if Jenny's sons are saying that she has OCD. Right? Is that your read too, Chris?
Yeah, I'm kind of
She's
getting it
not
like,
sure she agrees.
yeah, exactly. Yeah. Like her sons think she has it, but she doesn't. But now she's afraid that it might be there, kind of,
Yeah, I guess I would be curious if it doesn't feel too threatening to ask the sons, what do you notice? What types of behaviors am I engaging in that concern you? In what ways do you think I'm not able to live in line with my values or live a full life? Just to get a better understanding. And oh, she's dealing with it so much. Okay. So yeah, trying to bridge that gap. It might mean that having the sons come into therapy, to the individual therapy sessions, and just getting all on the same page could be helpful, because you want to make sure that if you're working to fight OCD as a family, that you're doing so in a way that everyone is recognizing the important and hard work you're doing, and for you not to feel like you're never doing enough.
Yeah. Yeah, I would say, Jenny, like one thing is always family therapy to get on the same page with an OCD provider. Sometimes family members have insight in OCD. It sounds like you're kind of actively resisting it. I think there's, your anxiety but your sons have it, your anxiety for them. I think, a biggest thing too is you were talking about the fear of like spiraling out of control with your anxiety. I think that's why seeing a licensed professional is helpful. A big goal is to give you strategies and tools even at some of your worst days, right? And so I think a lot of times, sometimes we fear the thoughts, we fear the feelings, and we fear the behaviors, and having strategies of what to do when they appear is super helpful. So all right, thank you, everyone. There's a couple questions we didn't get to. I put them on our question list. So those of you that asked medication or psychopharmacological questions, make sure to definitely be here the second Wednesday of the month. We have the psychiatrist to answer those. And there's a few questions we didn't get to, Lauren, but I put them at the top of our pre-submitted list to get to them next week. We'll be back here next Wednesday at 12 Eastern. Make sure you join us. Lauren, huge thank you for helping answer questions, being on the show, talking about relevant topics. Before you go, shout out MHTNI.
Yeah, minty. So if there are any providers watching, Liz Meckenville and I just launched a new app that is helping every therapist get access to evidence-based training. So we have wonderful speakers like Chris and Paskar and Hudak and all the folks that were shouted out today, I think. We'll have talks on the app. It's available on desktop and mobile at mhnti.com.
Yeah, so a big, huge thank you, of course, to Wadsworth for being on.
Thank you for having me.
Yes, I'll see Lauren in the group chat, and I'll be giggling all day in between clients. We'll be back next week at 12 Eastern. Make sure you check out everything that Lauren Wadsworth is doing. She's always keeping busy. And my only final thought is make sure to go to iocf.org for all of your OCD and related needs. And remember, OCD is a big fat liar. Don't listen to it. Thank you so much. And thank you to Dr. Wadsworth. Take care, everyone.
Thank you, Chris. Take care. Bye.
Bye.